Hello, I'm John Leonard from Weill Cornell Medicine and New York Presbyterian Hospital. It's a pleasure to be here to provide you with these key insights from the Great Debates and Updates in Hematologic Malignancies meeting here in New York. We've had a great session today covering various lymphoma topics. We had a full audience, great array of speakers, and really trying to focus on topics that are important to the practicing physician, new data, as well as controversies that are important to patients, important to clinicians as they approach patients in their practice. So we started off with a number of different areas. The first area was looking at Hodgkin lymphoma. We have a number of new agents in Hodgkin lymphoma. Beyond chemotherapy, we have brentuximab vedotin, an antibody-drug conjugate. We have new immune checkpoint inhibitors. And so the question really that we tackled in our first debate was, what is the role of novel approaches as second-line therapy in Hodgkin lymphoma? As the audience no doubt knows, patients with Hodgkin lymphoma largely are treated with ABVD chemotherapy. When patients relapse, for the vast majority of patients who are younger and candidates for more therapy, we traditionally have treated these patients with chemotherapy and moved on toward an autologous stem cell transplant. With the availability of new drugs like brentuximab vedotin, which is active in relapsed patients and active in the multiply relapsed patient, including post-transplant setting, the question has come up, should we use these drugs earlier in the course of treatment? And so there are big trials going on right now, randomized phase 3 trial looking at using brentuximab vedotin in the upfront setting. And what we debated today, and we had Nancy Bartlett and Ann LaCase talk about the use in second-line therapy of either the standard chemotherapy approaches such as ICE or gemcitabine, vinorelbine, and liposomal doxorubicin being one example, or should we be using, and this is off-label, should we be using brentuximab vedotin in combination with chemotherapy? And there are regimens out there with the ICE chemotherapy regimen or with bendamustine. And so we debated these issues. It was a really nice debate. I think the key take-home message from that debate is that brentuximab vedotin has a relatively low CR rate, and I think the main point is that CR going into auto transplant is key in that it correlates with long-term outcomes. So the goal of second-line therapy should be getting the patient into CR, and that CR, if achieved, is associated with a much better progression-free and overall survival. So brentuximab alone is not effective as a single agent in that setting, but chemotherapy alone or chemotherapy with brentuximab seem to be associated with high CR rates and good outcomes. We really do need randomized trials to show what is the best second-line regimen in Hodgkin lymphoma. We then moved on, and Tom Haberman covered both sides of the discussion around maintenance therapy in diffuse large B-cell lymphoma. This has been an area that Tom has worked on for many years, going back to the original rituximab CHOP versus CHOP alone studies. The ECOG 4494 study looked at maintenance rituximab, did not show a maintenance rituximab benefit after R-CHOP, and therefore maintenance therapies really have not been adopted in large cell lymphoma. There have been a number of studies, including looking at everolimus as one example, enzastorin is another example as maintenance therapy after R-CHOP. Really no clear benefit there. We've had some more recent data with lenalidomide, looking at lenalidomide maintenance after R-CHOP, showing, I would say, a modest progression-free survival benefit, but no clear overall survival benefit. So as of today, there is really little role or no role for maintenance therapy in diffuse large B-cell lymphoma after R-CHOP. So that was an important discussion for the audience, important to keep in mind for your practice, that as of now, there is little role for maintenance therapy after R-CHOP and diffuse large B-cell lymphoma. Nancy Bartlett then came back and gave us some information on the Deauville score, which is an important measure of PET outcomes. In other words, using PET after therapy to assess the therapeutic response. This is relevant to follicular lymphoma, relevant to Hodgkin lymphoma, also very relevant in large cell lymphoma as well, both as a correlative outcome, and in particular in Hodgkin lymphoma, using this as in a PET-adapted approach to try to change therapy based on the outcome on a PET scan, either as an interim step or at the end of treatment. And the Deauville score, which was developed in an international conference, was really developed to and has evolved into a tool to look at PET uptake relative to various organs, including mediastinum and liver, and try to quantitate the degree of positivity or negativity. And I think Nancy's take-home message was that the Deauville score is still open to some interpretation. You can't just go by SUV numbers, and in particular, the Deauville 4 score, which is in relation to liver, is a very important category, because that is a category that if you call a patient Deauville 4, that's really considered a true or still a positive PET scan. But there is some subtlety to this in that the level of SUV uptake in a PET scan after therapy can be just slightly over the liver uptake, or it can be substantially over the liver uptake. And those two patients, those two scenarios are not exactly the same. And the approach to those two scenarios is really quite different in some cases in clinical practice. And so the message there, I think, is really all Deauville scores, all Deauville 4 scores in particular, are not the same, and one really needs to sit with your radiologist in these questionable cases, make sure they're applying the criteria properly, and talk through the case with the radiologist so that you're not changing therapy either with less therapy or more therapy based on an indeterminate or an improper or inaccurate, I should say, assessment of what that score means. So this is an area that I think still needs some refinement, and Nancy highlighted the importance of this as we move forward in treating our patients. In the later part of the session, we had an additional debate. We had Tim Fensky and Peter Martin debating what is actually a common debate topic, and that is, what is the optimal upfront therapy for mantle cell lymphoma in a relatively younger patient, a patient who might be a candidate for a less aggressive approach or a more aggressive approach in their outcome. One of the key pieces of information that Peter in particular highlighted was the importance of p53 mutations as a prognostic marker. Patients that have abnormalities of p53 tend to have a very poor outcome in mantle cell lymphoma no matter how you treat the patient, whereas those that have normal or intact p53 tend to have a more favorable outcome as a group. And so that is a marker that I think may be emerging a little bit more over time in clinical care. The pros and cons for patients with mantle cell lymphoma of a less intensive approach associated with less severe toxicity in the short term, but a shorter remission, therefore an earlier relapse, versus a more aggressive regimen and a transplant-based regimen associated with more acute toxicity, but a more durable remission, is really a patient-individualized, patient-centered, I would say, a decision where we make these decisions in consultation with the patient to a large degree, where the long-term outcomes and overall survival may be quite similar with each approach, but yet there are very big differences in the patient experience. And I think all of us in our practice, as we see mantle cell lymphoma patients, are confronted with the challenge of a patient, perhaps, and Peter highlighted this well, someone in their early 60s might be considering retiring but still working. Do you try to give them a regimen that they can take as an outpatient, continue to work and do their normal activities, albeit a regimen that's associated with a less durable remission? On the other hand, do you ask that patient or suggest to that patient that they would be better off taking 6 to 9 months off of work, getting a more intensive regimen? How does that impact their life? the trade-off is that they are likely to get a longer remission. And so those are really, that's what it's all about as far as being an oncologist. And I think we, in the art of taking care of patients, talking to patients about these decisions and the impact on the patient's life. And I think we had a great discussion about some of the issues there and how one might approach these situations in one's practice. Next, we had discussion around the issue of CAR T cells. CAR T cells, as the audience no doubt knows, are getting a lot of attention from patients in the press. There are companies developing CAR T cell projects, or products, I should say, to treat various B-cell malignancies, including ALL. And we have several different CAR T cells in clinical, CAR T cell products in clinical development over the current time, and in fact over the coming months to years, it's quite possible that we may have them available to our patients. And so we had Jeremy Abramson give his thoughts on what sorts of patients, what is the patient population that may be likely to receive CAR T cells at some point in the near future. CAR T cells have gotten a great deal of attention from patients in the news, as I said, so your patients may be asking you about those, and it's likely that it will be a relatively small percentage of patients, if any, that get CAR T cells in the near future, although it's possible that these indications will expand over time. Jeremy presented the issues around CAR T cells, a little bit about what the products actually are and how they're generated, the fact that there are some steps in the generation of a product, and so when a patient is freezed to collect T cells in order to generate a CAR T cell product, there may be anywhere from a 2 to 4 week, or in some cases longer period, where the patient will have to be in a holding pattern while they're waiting for CAR T cell generation. And some of these studies have allowed some interim chemotherapy. Some have expected that the patient would just wait and have disease that could wait, and these inevitably result in some selection biases who go on to these studies. Nonetheless, the response rates to CAR T cell products in aggressive lymphomas, and that's where we seem to have the most data so far, seem to be associated with high response rates and quite meaningful CR rates. The question in my mind, and I think was raised in the discussion, is really how durable the complete remissions will be, and will these be just short-term responses, or will there be a population of patients who can have a durable complete remission with this? And then at some level, if this ends up being a minority of patients, who is the patient that will get these therapies in the future? And Jeremy highlighted that he thought, and I think others would agree, that the refractory large cell lymphoma patient population may be one in the future who will receive these products, but there's a great deal of work to do in the refinement of CAR T cell constructs and products to make them more effective, and importantly make them less toxic, because they have been associated with a variety of side effects, including a cytokine release syndrome and neurologic toxicity that in most cases is transient but rarely can be life-threatening or even fatal. And so I think there's still work to do about CAR T cells, but that is an area that we will no doubt be talking about and hearing about more, because this may well be a modality that's available to our patients before long, and we are really going to have to figure out how to use these in our practice and which patients are the most appropriate candidates. Finally, in our last debate, Jonathan Friedberg and I debated the appropriate choice or the therapeutic options that are out there for initial therapy for follicular lymphoma. And in particular, we heard over the past 6 months or so data on obinutuzumab, a novel anti-CD20 antibody that's been approved for CLL, approved for recurrent follicular lymphoma in subsets of patients. And in fact, we had the Gallium study presented at the 2016 meeting of the American Society of Hematology that randomized about 1,200 patients to either obinutuzumab with chemotherapy or rituximab with chemotherapy, followed by maintenance with both one or the other agent for 2 years. And the findings of that study suggested that there was a progression-free survival benefit to the addition of obinutuzumab, somewhere at the 3-year mark being about a 6 to 7% difference in 3-year progression-free survival. This is at a cost of some toxicity, a little bit more in the way of infections and infusion reactions, but nonetheless, a progression-free survival benefit without an overall survival benefit suggests that there may be some benefit for patients, albeit with respect to progression-free survival and not at this point overall survival. And so we debated the pros and cons of obinutuzumab. I think issues that came up that were takeaways for the audience included the fact that the obinutuzumab upfront data is all after or with chemotherapy as a maintenance treatment and with the chemotherapy. And the issue there is that these patients, all in these trials, received a maintenance treatment. And there are some patients with follicular lymphoma who choose to get treated with single-agent rituximab, or they choose to get treated without rituximab maintenance. And so for those patients who do not want maintenance or who want single-agent antibody therapy, the data at this point do not guide us with respect to obinutuzumab use. And so I think there's more to come. I don't think that obinutuzumab is the answer for all patients, but there are clearly some patients and physicians who, in some cases, may choose to use it as a treatment. We also had some interesting highlighting of the fact that bendamustine followed by bendamustine antibody therapy followed by antibody maintenance, again either obinutuzumab or rituximab, were associated with a few extra early deaths, meaning that there were patients getting bendamustine with antibody therapy followed by antibody maintenance. There were a few early deaths that occurred in excess compared to the CHOP antibody arms, and that raises the question as to why bendamustine-based therapy with maintenance might be potentially more toxic. This is something that we're still looking at as a lymphoma community, but something to keep in mind as we look at these data and further studies. So again, I think that this remains an important issue and one that will continue to evolve over time. So I think the great debates and updates in hematologic malignancies program has really been a fabulous venue to get the latest information, to hear experts talk about how they treat patients in their practice, to get different perspectives on some of the key debates and controversies in hematologic malignancies. And the key updates from this really, I think, are things that people can take home, use in their practice, think about as they approach patients, and are certain to evolve in the future as we continue to see emerging data in clinical trials and apply them to treating patients in our practice. Thank you very much for joining me today to review these key updates from the meeting.